I'm Dr. Clayton Molliver. I'm a clinical professor of surgery in the Division of Plastic Surgery at UTMB, Galveston, and a clinical editor of the Aesthetic Surgery Journal. I want to talk to you about BII today, breast implant illness, and my personal algorithm for how to take care of it. So I won't get into the diagnosis of BII or what the symptoms are, etc. People come to me all the time, they think they have BII. Frequently, they say they're not really sure, they just want their implants out if possibly it'll make them feel better. I think that's fine. I don't have a problem with that. I think there's studies that suggest that there's a tiny proportion of women that develop autoimmune response to silicone, be it saline or silicone. But be that as it may, here's my algorithm. Patient comes in, they feel like they have BII. So, my question to them is, do you have saline implants or do you have silicone implants? And then, if you have saline implants, and do you have a history of ruptured silicone, or do you have a history of silicones before that? Once we know which one you have, the next step, in my opinion, is to get a high-resolution ultrasound. I think it's vitally important. Now, most ultrasound reports are read by radiologists, and they're read in the following manner. They want to know, or they'll tell you whether they see any breast disease in the breast tissue, and whether the implant is leaking or not, within a pocket that the body lays down soon after a breast augmentation is performed, or at least the pocket controls itself. It becomes sealed off. But in our practice, we do the ultrasound here. We have a high-resolution ultrasound machine here. It's done by an ultrasound technologist, and it's read by a board-certified radiologist who specializes in breast disease. And I have the radiologist comment about the thickness of the capsule, and if it's there. There's not always a capsule, which is a common misconception. People think there's always a capsule. That's absolutely not true. Sometimes there isn't. It's just a pocket. So, if there's a saline implant intact, in place, and we get the high-resolution ultrasound, then the next thing we want to know is there a capsule or is there no capsule? If there's no capsule whatsoever, we can explant under local anesthesia or general anesthesia. Sometimes when we take these implants out under local anesthesia, there is a thickened area of capsule, and it's a bit more difficult to start taking that out under local anesthesia, but it certainly can be done. Under anesthesia, we can do the explant and total capsulectomy. So that's how we do it with saline implants. There is never an indication for en bloc capsulectomy when you have saline implants and you have had no history of silicone implants, in my opinion. You'll hear differently that en bloc is always necessary. That's a money grab by plastic surgeons who want to charge more and always do an en bloc. The fact of the matter is that once the saline implant is removed, there is nothing else left behind that's silicone. It doesn't leave particles of silicone if it's a smooth implant, so it's just not necessary. If it's textured, it might leave particles, and it might be a good reason to wash out the pocket and do a total capsulectomy. If portions of the textured surface are impregnated or stuck or broken off into the scar capsule, in which case a total capsulectomy is reasonable. And that's where we take out the entire capsule in sections through the smaller inframammary incision. If it's a silicone implant, we get the high-resolution ultrasound. If it says it's ruptured, en bloc. It's perfectly justified to do an en bloc there to not leave any clumps or pieces of silicone behind in the pocket. If there's clearly no rupture and there's no capsule, then it's just an explant and no capsulectomy is needed. Of course, if we find thickened areas of the capsule, then sure, we can take out those areas. If there is no capsule, if we're looking at muscles and bone and nerves, etc., then taking off a layer of that is just damaging to the tissue, and I won't do it. It's just going to cause you more pain and more problems down the road. If, on the other hand, there is a capsule, then we can do explant and total capsulectomy. Which drives another question, and that is, why are we taking out the capsule in any of these cases when the implant is intact? And I have my own theory about that. While there is some studies that suggest that they may cause an autoimmune disease, meaning saline or silicone implants, my own feeling is that if there's a capsule, we know that this is bacterially mediated. And that means that the scar capsule, the scar tissue that's formed around the implant, has bacteria in it. And in my view, this is probably causing a chronic inflammatory condition, which can make someone potentially feel bad. I think it's perfectly reasonable in that case to do the capsulectomy. But you don't need to make a incision all the way across the breast and take out the entire capsule with an intact saline implant or an intact silicone implant. It's just foolishness, and it's damaging to the tissues. And frankly, it's not necessary. I don't want to do anything that's not necessary, charge more, or do more damage to the chest wall. So this is my algorithm. This is how I take care of it. If you have any questions, please send me a DM, and I'd be happy to discuss it with you.